Welcome everybody. Thank you for joining tonight. Our topic tonight is on DBS, or Deep Brain Stimulation, as a treatment for Parkinson's disease. We'll get underway. Okay, there you go. Right, so just an outline of the talk. Just to give it a bit of context, we'll talk about Parkinson's disease and its progression and how and where DBS fits into that, how it works for Parkinson's, what the benefits are, what the risks are, just as there are risks with any treatment. And then an important question for many of you, is DBS right for me? And if not, then what are the alternatives? And then finally, as Andrew mentioned, we'll have a Q&A session at the end. I guess you'd know that in Parkinson's, what happens is you lose these dopamine-producing cells in the brain, which are based in the midbrain, quite deep in here. So that's the substantia nigra is what it's called. And dopamine is a neurotransmitter, so it's a chemical used for signaling between neurons or brain cells. And so you can see here, this is how neurons communicate. And when you lose dopamine, that affects this communication. And importantly, dopamine is involved in movement. So that affects movement and the manifestations of Parkinson's disease. But it's not just movement. Dopamine's involved in cognition and behavioral functions as well. So this lack of dopamine can affect motivation and mood, for example. A little bit of anatomy just to help you understand what I'll be talking about when we go on to the next few slides on deep brain stimulation. So this is a slice of the brain looking from side to side. So that's one side here, the other side. And there's some deep structures here which are very important in movement. And they're called basal ganglia nuclei. And the substantia nigra I talked about is down here, which is where the dopamine producing cells are based. And this big nucleus here is the thalamus. Under the thalamus, there's a tiny little nucleus about 1 centimeter long, which is a subthalamic nucleus. And then we have the pallidum, the globus pallidus, which is another structure that is also important in Parkinson's. But our main interest is this subthalamic nucleus, and I'll explain how that is involved in a bit. Now, this is quite a technical slide, but I just want to point out a few things. Now, again, a picture of these nuclei here, the subthalamic nucleus, which produces or has neurons that produce dopamine, and that communicates with the other basal ganglia nuclei and with the surface of the brain called the cortex, and in this case, the motor cortex, which is involved in movement. And there are circuits between these nuclei, as you can see with these arrows here. And it's essentially, it's a loop. And these loops can be represented in these diagrams here. This is what normal should look like. And this is what happens in Parkinson's. And these signals get disrupted because of lack of dopamine from the substantia nigra here. And you can see some of these arrows are bigger and some are smaller than what would be signaling in a normal brain. And so basically the output from the basal ganglia inhibits the thalamus, and you get a reduced signal from the thalamus to the motor cortex, which results in a lack of movement or akinesia. And so with deep brain stimulation, our target is this subthalamic nucleus here. And you can see this becomes hyperactive in Parkinson's. This is a normal signal out of the subthalamic nucleus. This is a big signal out of it. And so when we put an electrode there and stimulate it, what that does is normalizes all these signals back to something closer to this here. So deep brain stimulation is electrical stimulation, and in Parkinson's, our usual target is the subthalamic nucleus here. And as I mentioned, it normalizes circuits that control movement in deep parts of the brain or the basic ganglia. And that actually helps reduce the cardinal motor features of Parkinson's, which are tremor, stiffness, and slowness. The advantage of this over medical treatments is that it's a constant and continuous treatment, which means there are no fluctuations or less fluctuations than you would get with medications. So this is a picture of the hardware here. So electrodes which are implanted in the brain, and then these wires come out and they're under the skin, and there's an extension cable that runs under the skin. So everything's internalized. And then there's a neurostimulator, or what we call an IPG, or implantable pulse generator. And that's got the battery and the chip. And then you get a patient programmer, and we have a clinician programmer that we can use to communicate with it and program it. Again, a picture of, so I'll just show you, we've got a sample of these. So that's the electrode, that's tiny, that's what goes in. And that's essentially the wire that goes under the skin. And that's the battery and chip, or the IPG. So that's just a picture of the electrode that goes in, and they have different contacts here. So there are different levels of contacts, and they're broken up into different segments as well. And we can activate different segments or combinations of segments to produce this electrical field. And so there's lots of options, hundreds and thousands of options in terms of what we can do with the programming. And so this one here is a version of the patient program. So it's more like an iPhone nowadays. And that's the clinician programmer there. There's a bit of history behind deep brain stimulation, and it's interesting. So I just thought I'd cover a little bit of that. So levodopa, which is the mainstay of medical treatments for Parkinson's nowadays, was only discovered in modern medicine in the 1960s. And some of you will be familiar with mucuna pruriens, which is derived from broad beans or fava beans. And that's known to have levodopa as well. And that's been used in Ayurvedic medicine for centuries, really. But it wasn't established as a treatment for Parkinson's in modern medicine until very recently. So before the advent of levodopa, the main treatment, effective treatment for Parkinson's, was surgical, and that was with making a lesion in this nucleus here, the globus pallidus. And that used to get rid of or improve motor symptoms of Parkinson's. The problem with that was it could only be done on one side, because treating both sides caused more side effects with loss of balance and speech problems. So with the advent of levodopa, this was abandoned, and people just got treated with levodopa and other medications. One of the other treatments, surgical treatments for movement disorders, was a similar lesion that was made in the thalamus called a thalamotomy. A thalamotomy is done for treatment of tremor. So it didn't treat other Parkinsonian symptoms, it just treated tremor. But it was used for Parkinson's for some people, just to treat tremor on one side. And then the advent of deep brain stimulation was really in 1987. There was this neurosurgeon, Alim Benabid, who was performing a thalamotomy for treatment of tremor in a patient with Parkinson's. And he was a physicist as well. And so with the probe that he was using to burn this thalamotomy lesion, he thought he'd experiment and And what he did was he just put some electricity in without, so it wasn't enough to cause a lesion, but just to stimulate the nucleus. And he found that resulted in improvement in tremor in the patient. And when he stopped the electricity, that tremor came back. So that really was the birth of deep brain stimulation. So at that point, it was done in the thalamus for the treatment of tremor. But of course, for Parkinson's, we needed something else. And over time, scientists realized that this little nucleus, the subthalamic nucleus, was important in Parkinson's. And so what they did was they produced Parkinson's in monkeys using this chemical called MPTP. And then they stimulated the subthalamic nucleus, and that seemed to resolve Parkinsonian symptoms. And so that was how DBS came around for Parkinson's. So this was in Grenoble in France, where this team worked on this procedure. And then they subsequently did this in humans with Parkinson's and found that it worked. And this was in 1993 that the first human was operated on. And following that, the same group then showed in a whole series of people with Parkinson's that this was an effective treatment. So you'll be familiar with these medications, at least some of them. So levodopa, either in the form of Sinemet or Medapa. There's dopamine agonists. So some of you may have tried this or maybe on these, pramipexole or ropinirole. And these work on dopamine receptors. Then there's enzyme inhibitors, which prolong the effects of levodopa in the form of entacapone or tolcapone. And another enzyme inhibitor called rasagiline, which is a pretty modest, mild treatment, not very frequently used. And finally, there's amantadine, which is the most useful use of it is for the treatment of dyskinesias or involuntary movements which happen as a result of levodopa treatment. So in terms of what happens with Parkinson's motor symptoms over the years, we can show that on a graph here. So if the arrows here represent levodopa doses, and this is time. So as time goes on, you'll see that initially we're in this white area, which is where we want to be. But as time goes on, people experience dyskinesias or extra movements with peak doses, and also off symptoms when it dips below, and that gets worse over time. So this white bit becomes less and less, or a smaller part of the day. Another way to show that is in these graphs here. So early on in Parkinson's, and many of you will know this, you usually get started on Sinemet or Medapa 3 times a day, and that's sufficient. It lasts for many hours, and that's because you have enough storage capacity in your brain to store the levodopa or dopamine and then release it when needed for movement. So you might take levodopa many hours apart, and that's sufficient. And you stay within this therapeutic range that we want here. As time goes on, you need more frequent doses, and one of the earliest fluctuations people have is wearing off. So before the next dose, you dip below this akinesia threshold and you get off symptoms. You might get recurrence of tremor, slowness, stiffness, and even non-motor symptoms. And with further progression, things become more erratic. So as you can see here, there's multiple doses a day quite close together, and the response in terms of the levels and the effect of each dose is quite erratic here. So the question is, who is DBS right for? There are 3 main indications, and the biggest one is motor fluctuations or dyskinesias, which are not controlled by oral medications alone. So that's what I showed in the last couple of slides. The second is sometimes people have a tremor that is not very responsive to levodopa or other medications. And we know that DBS helps tremor better than medications can. So that's the second indication. And then the third is a smaller group of people where you have a severe intolerance to levodopa or the other medications, and therefore you can't take much to treat your Parkinsonian symptoms. So those are the main indications. And then there are features that make people not so suitable for DBS. And one of these is poor balance. So sometimes people have poor balance when they're off, and that improves when they take the medications and turn on, and the balance then improves. So we're not so worried about that sort of poor balance. That's only in the off state. But if you have poor balance in the on state, that will tend to get worse with DBS. So that's a bit of a concern. The second is poor cognition, and we know that DBS can have some adverse effects on cognition. It's pretty mild, but if you have a poor baseline to start with, then that's something that weighs against you. And a similar caution applies to psychological and psychiatric symptoms. And again, sometimes, so these can be, they can be from the Parkinson's, but they also can be worsened by medications. And if it's predominantly medication related, then in fact, having DBS and reducing the medications can help. So there's we need to get into assessing what exactly these, how much of each is contributing to these symptoms. And finally, it is brain surgery. So if someone is not suitable for surgery and not suitable to have anesthetic because of lots of other medical issues and cardiac and respiratory problems, then that's something else we do consider as well. Just as with any treatment, and particularly with surgical treatments, there are procedure-related risks. So we can divide these into surgical risks and stimulation-related risks. So with surgery, the greatest or the worst risk really is a very small chance of having a stroke from a bleed when the electrode is put into the brain. And obviously we try to minimize the risk of that by looking at the scans very carefully and avoiding blood vessels. But despite that, just hitting a small blood vessel can sometimes result in a bleed. And the chance we quote is about 1%. Actually, in our center, it's much lower than that based on our record so far. But it is something that you need to be aware about. The second surgical risk is infection involving the hardware. So if you get a bug into your bloodstream, say from dental work or other infections, that can latch onto the hardware, and then it can track into the brain and cause a serious infection. And if that's the case, we need to take the whole system out and replace it at a later stage, usually in a few months' time. The risk of that is about 2 to 4%. And thirdly, part of the surgery involves having a general anesthetic, and that's something else to consider, so the anesthetic risk. Then there are stimulation-related side effects that you can potentially get. And I've mentioned worsening of balance and on freezing. So this is why we want to make sure that your balance is actually good at baseline before you get DBS. One of the common stimulation-related side effects from spread of the current around the structures where we put the electrode is slurring of speech. And occasionally we get mood and behavioral changes and impulsiveness. Usually we can deal with these by changing where we're stimulating and the different parameters that we can control with the programming. Another common side effect is weight gain. And it may be from increased appetite, but also a lot of people who have lots of dyskinesia and tremor, suddenly after surgery, when that resolves, they're not expending as much energy. And so that can result in weight gain as well. So what could you expect in terms of benefits? If you have dyskinesia as a major problem that constitutes your motor fluctuations, you can expect this to greatly reduce or stop after surgery. So most patients we see with dyskinesias, they settle down completely or near completely after DBS. And that's because we can reduce the medications that cause dyskinesias. And most people can reduce their medications by about a half. This is individualized and we tailor it to um, your case and the effects of the DBS, and the medications are adjusted accordingly. But for most people, it's about a half. The other major benefit in terms of motor symptoms is an improvement in off symptoms and an increase in your on time. And so for both of these, it's about a 70% increase compared to before DBS. Now, to show you, there's a patient of mine who very kindly volunteered to share his video so he's had DBS, and this is showing the effects of the stimulation on and off. And so I'll just play this now. So this is with the DBS off initially. So you can see quite a bad tremor there. And do the finger taps in the right hand, left hand, and right arm out like this and turn back and forth. So just demonstrating the slowness of movement, which is worse on his left side, in fact. Okay, put tapping with the right and left. Okay. And now the DBS is just switched on with the remote. And turn your palms up. You can see the tremor just goes. And with your right hand, can you do the finger tap down straight away? Writing fast as you can. Left hand. Okay, and put your arm out like this on your right and turn back and forth as quick as you can. Other one. Okay, and just with your right foot now, heel on the ground and tapping wide and fast as you can. And the other one. Excellent, okay. So that's just to demonstrate, and the effects are pretty immediate. So once we get the programming right, you can just switch it on, and the effects are pretty much straight away. Improvement in tremor control, you've seen that. And the other benefit is reduced side effects of medications. So some people get lightheadedness or ongoing nausea sometimes with levodopa or other medications. It can exacerbate behavioral changes, confusion, hallucinations, and all those things can improve with a reduction in the medications. And that's a positive effect of having DBS do half the job rather than just using medications. So what's involved? What's the process? So I've categorized these in three stages: the preoperative, the day of the surgery, operative, and then post-operative. And so the first step, if you think you or someone might benefit from deep brain stimulation, is to discuss it with your local neurologist. In a large center, this is usually a movement disorder neurologist, but even a general neurologist looking after you for your Parkinson's can talk to you about this. And if they think it's a good idea, they would make a referral to the DBS Centre in Auckland, and you would get a clinic appointment with one of the DBS neurologists, myself or one of my colleagues, and we would talk to you about it and have a discussion about DBS. And if we both agree that it's the right thing to do, as in us and yourselves or the patient, then we would proceed to a set of pre-assessments before we make the final decision to go ahead for with surgery. And these assessments, there are two main ones. One is the levodopa challenge, and that's where you come in off medications on a morning, and we assess your motor symptoms off medications. Then you take your medications or a dose of levodopa, and we do another motor assessment afterwards. And this is important because the response to levodopa is actually a very good indicator of what you can expect as a response to deep brain stimulation. So the greater the response to levodopa, the more likely that DBS is to help. The second assessment is a detailed neuropsychology and neurocognitive assessment. And we then use these along with the clinical history, and we would review this in our DBS multidisciplinary meeting, where we have the surgeons, the psychologists, psychiatrists, and other neurologists, and review the results of these tests and your case. And if we think you would benefit from DBS, then we would book you in for the surgery. So in terms of what's involved on the day, there are two stages to the surgery. The first is implantation of the electrodes into the brain, and then the second is the battery in your chest. And the first stage is done with you awake. The second stage is done under general anesthesia. And the reason we want you awake is you will have some sedation and light sedation and pain relief. But it's important to have you awake so we can actually assess the effect of the DBS once the electrode's placed. So you have an MRI scan close to the time of surgery. You come into hospital a day before. We withhold your medications overnight because we want to have the Parkinson's symptoms, whether it be tremor or stiffness or slowness, present on the morning or at the time of the surgery, so we can assess the effect of the stimulation. Like I mentioned, you get local anesthetic. So you have this frame placed over your head, and to make it comfortable, you get some local anesthetic and nerve blocks and a bit of light sedation. You have the frame placed, you have a CT scan with the frame, so we can use that along with your recent MRI to plan our trajectory, so we make sure we get into the tiny nucleus, the subthalamic nucleus, which is very important. So we can record signals as the wire is advanced, and there's a very specific signal that the subthalamic nucleus gives off, which is very useful. And we can confirm that we're in there when we hear that signal. So these are called microelectrode recordings. And then once we're in there, or we think we're in there, we do some clinical testing. So we actually turn on the stimulation at the time, and it's useful if you have a tremor, because we want to see the tremor settle down, just like we saw in that patient earlier on. But if you don't, and some people don't have a tremor, we use things like stiffness, rigidity to test the effect of DBS. The other thing we test for is side effects. And if you have significant side effects from the stimulation, we would sometimes adjust the location of the electrode to deal with that as well. So we want to see a good result at a time, so that when it comes to programming post-operatively, we have a really good result from the DBS. And so that's the first stage, and then you have general anesthetic for the second stage, get the battery placed in, and then the wires get connected. Third stage, post-operatives. So you continue with your medications as usual initially. We allow about 2 weeks from the time the electrode's placed, because there's a bit of stun effect, or resulting from swelling in the subthalamic nucleus. And we want that to settle down before we start the stimulation, so we can get a true idea of what the stimulation is doing. And so we book you in. We have 2 DBS nurses who are very highly specialized and trained in this, and they would. So what we do is there's 4 electrodes, as you saw in that wire, 4 levels of contacts. And we test each one and document the effects um, of the DBS on your Parkinsonian symptoms and the side effects. And then that helps us choose the best one for you. And then we activate the stimulation. And over the subsequent weeks and months, um, as the stimulation is adjusted and ramped up, we guide you with the medications and reducing medications. And in fact, the best result is achieved from a combination of medications and stimulation together rather than just one alone. So following that, you'll have a follow-up appointment with one of the DBS neurologists in clinic, and we fine-tune things at that point, look over your medications and make further adjustments. If you have any problems with the deep brain stimulation, we'll deal with that. And then even if you're from out of town, we still would like to have at least a 12-monthly follow-up, so we can check your battery and the whole system at least yearly. So a few points to remember about DBS. It does not work any better than the best effect of levodopa. So that's one thing to remember. The advantage is that it is like having the best effect of levodopa all the time. So we get rid of the fluctuations. So it is more consistent. I've mentioned that a good response to levodopa indicates a good response to DBS, except in the case of tremor. So some people don't have good tremor control with levodopa, but we know with subthalamic DBS, there is a better effect on tremor. The second thing to remember is that it does not slow down the progression of Parkinson's. Because people often ask how long the DBS works for, how long it lasts for, and the answer is forever. It's indefinite. The effect is indefinite for as long as you have it, but it only works on the symptoms it treats, and that's tremor, stiffness, slowness. It doesn't treat all Parkinsonian symptoms, and many of you will know that there are many non-motor symptoms, cognitive symptoms, and these do not respond to DBS, and they may still progress. So things like cognition and balance may still get worse as usual, but the motor symptoms are well controlled with deep brain stimulation. And the third point is that you will still need to be on some medications, but they'll be less frequent and you'll have smaller doses of them. And most people can come off what we call adjunctive treatments like dopamine agonists, often amantadine, and just stay on levodopa with less frequent doses and smaller doses. And what if DBS is not for you? What are the alternatives? One of them, and some of you may be on this already, is an epinephrine pump. So I'll talk about that in more detail shortly. I'll just mention this duodopa intestinal gel because you may read about it. It's not funded in New Zealand, but this involves getting a peg tube or hole in your stomach with a tube that extends down into the small intestinal jejunum, and there's a pump with essentially it's got a gel form of Cinemet, and that's infused continuously, so you don't have the fluctuations as much as taking pills. But that's not available, so we won't spend too much time on that. And the third one is not really an alternative to DBS, but we get asked about this a lot. So I will talk about this, and this is focused ultrasound telemetry. So just going into those now. So epinephrine, so it's not morphine, it's a dopamine agonist, and it's in the class of medications of pramipexole and ropinirole, but in fact, it's actually more similar to levodopa. The effects are more like levodopa. And the advantage, so it's a device-related therapy like DBS. The advantage is that it's continuous. So you have this syringe with epinephrine, a pump, and we can set the rate here. And there's a tiny needle that just goes under your skin, so it's subcutaneous. And you just put this in a pouch or your pocket, and it infuses all day and all night if you need that. So this also helps reduce fluctuations, and that's the main use of it. So it helps reduce off time, increase on time without dyskinesias. And in the studies looking at this, it's about 3.5 hours a day of extra on time without dyskinesias. Side effects, one of the most common ones is skin nodules. This can be minimized by changing the site where you insert it every day and massaging the area. And sometimes people get somnolence or sleepiness. And if you have hallucinations or some cognitive impairment, this can make that or make hallucinations worse. Advantage over DBS, it's quite easily reversible. So you can try this, and if it's not for you, you can always stop it. So it's less invasive. It's not surgery of any sort, and it's much less invasive. Coming to focused ultrasound thalamidotomy. Now, the attraction of this for a lot of people is that it's perceived to be non-invasive. And in a way it is, because you don't need, it's not a surgery where you get burr holes, but it is still burning a lesion in the brain in a non-invasive way. So you don't need any incisions. And the way this is done is you have an MRI machine that that's used to give us real-time images of the brain to show us where we or what we're treating, to target these ultrasound waves. And this is the ultrasound transducer, which emits ultrasonic waves from around the skull. And there's a focal point in the thalamus. And what that does is it heats it up enough to cause a lesion. And you can see that here. So, and this is kind of a heat map that shows where the lesion is. So it's a bit like using a magnifying glass to concentrate, the sun's rays to cause heat. So it's kind of that principle. Now, this is, you recall from the first few slides, this is done in the thalamus. In the thalamus, lesions or stimulation in the thalamus only treats tremor. So this only treats tremor. It doesn't treat other Parkinson's symptoms. So it doesn't treat stiffness, doesn't treat slowness, unlike deep brain stimulation of the subthalamic nucleus. So that's one point. And secondly, it's done on one side only, just like you recall from the earlier slides. Surgical lesioning is not done on both sides because of the side effects and negative effects on balance and speech. So at present, this is only done on one side, and it can't be adjusted like DBS can be. So if you have a good effect or a bad effect or a side effect, whatever you have at the time of the procedure is what you have long term. So that's the second point. And thirdly, we actually know that this procedure doesn't work very well for Parkinson and tremor. So even if you have tremor as a main manifestation, it tends to work for a short period of time, and then the effect wears off after a few months to after a year. So this is not a good alternative to deep brain stimulation. It is useful for other conditions like essential tremor and dystonic tremor. And just to mention, there are some studies looking at doing this in the subthalamic nucleus, and also doing it bilaterally, as in both sides of the brain. But this is still in research phases, so it's not done for Parkinson's for that in those forms yet. So to summarize, deep brain stimulation is a highly effective and safe treatment for motor symptoms of Parkinson's disease. However, it is brain surgery, and there are small potential risks to be considered. The main benefit is seen with people with significant motor fluctuations that are not controlled with medications alone, those with tremor that is not controlled with medications, and those with medication-related side effects where people can't take enough to control their symptoms. And for selected people who are suitable for the procedure, who fall into this category, it is the standard of treatment worldwide. So I'll finish there.